to have a bit of a brief that perhaps it's more about how we work together is going to be useful this afternoon as opposed to hearing too much about what we do and some other people are in. Is that? Yeah? Okay, perfect. So therefore, I might be flipping through a few slides just to get us into the right place. That's just a bit about how we're set up and why we're set up. I suppose the most important thing in terms of setup is that we were quite new, so October 2016 is when the service became a specialist service and taking eating disorders out of generic hands into specialist eating disorder services. So in that time there's been lots of changes to the service and resourcing that's been continuing. So we cover the whole of Berkshire and we're working out of two bases, so we have one in Maidenhead and one in Reading. We are a Monday to Friday 9 till 5 service and we accept young people from age 8 to 18. Quite exciting though, we've just started looking at an all-age eating disorder service. We're working very closely with our adult colleagues and looking at particularly the age 17 to 25-year-old age group, so to prevent some of that transition at age 18 when they're already in a really disruptive period of their life going through A-level to university transition. So that's a really exciting development for us that hopefully will be of benefit to you also. I won't talk too much about this, but just I think it's helpful for the understanding. So we're bound by something called access and wait times driven through NHS England, recognising the urgency of getting young people with eating disorders help quickly. So anyone presenting in what we would call urgent, so mainly they're the ones that presented already to a physical health hospital with ill health. We have to see them within 24 hours or provide treatment to the hospital supporting them within 24 hours. We then have urgents. We have to see them within 1 week and routine within 4 weeks. So I'm sure you can appreciate, as much as that's excellent for the young people, it can also provide some pressures to the service in delivering those access and wait times. And pleased to say we're doing okay at the moment. We've had some struggles in meeting those, but at the moment we're doing really well. We deliver nice concordant treatment, as you'd expect and hope for. Very multi-agency working, and in terms of even just who we've got working within our service, it's incredibly multi-agency, and along with our CAMS general colleagues who are here today. Okay, I won't talk too much about referrals, but just again, what might be useful for yourself. So over 80% of our referrals come from our GP colleagues. So very small numbers from elsewhere. Referral pathway. So all our referrals come through to the common point of entry. This is probably, I think, a really, really important little nugget of information for yourselves to think about when referring. We've had, I'm just going to see if there's, where it goes on to. The information on the referral form is probably the most significant bit to whether they get seen, whether an urgent or non-urgent, or whether it even comes through to our service. So common point of entry almost are our gatekeepers for our referrals getting to us. So no referral will come directly to us. So when information such as fussy eating, fuddy eating, eating problems are put on the referral form, that will not generate a referral to us. So it would have to have eating disorder cognitions, significant weight loss, or significant distress due to eating cognitions or problems that are affecting life. So because CPE will look at problems with eating, picky eating, faddy eating, eating problems, and for them, quite rightly, that might be due to anxiety, it might be due to physical health, it might be a young person who's on the autistic spectrum disorder has got some sensory issues around food. So what we're trying to do at the moment, we've just gone through our comms department, so that we actually have a drop-down click box that says that we want the referral to go straight through to eating disorders when you send your referral through to common point of entry. To just try and make sure that we get our referrals in the timely manner that we would hope and you would hope. What will also be on that drop-down is a weight and height and blood pressure link, so that all referrals generated coming in will have to have that information before we look at it. And I'll talk a little bit about why that's so relevant shortly. So what's the evidence? Early intervention associated with improved outcomes. early weight restoration predicts good outcome. So the quicker we see them, the better their prognosis, and the less chronic they become going into adult services. Specialist outpatient treatment is best for most cases, and family involvement is important. I'll talk a little bit about, just a little bit, for your understanding about what that looks like a little bit later. But the treatment approaches, so nice concordant treatment, it says family-based treatment, that's moved on slightly a little bit, it's now called family therapy, Anorexia Nervosa, or family therapy, bulimia nervosa. So the language now is FTAN, FTBN, but basically it's stemmed from family-based treatment. So it's called family therapy AN and family therapy BN, but, so I am a family therapist myself, so many of us will go, don't call it that. Because we're not doing family therapy. Why it's called family treatment and family therapy is because we're looking at the systemic issues, so all the issues around the young person that's maintaining the eating disorder and where the shifts need to occur in the system. So that system may be school support, it may be faith support, so it could be multiple reasons as to why we look at the system. So often there's maintaining factors within the system that is keeping the young person unwell. It might be, where we then draw in social care, for instance, because we think that might make the shift that's needed to support the young person in refeeding. Cognitive behavioural therapy, and that is explicit to eating disorders, so it's a specialist cognitive behavioural therapy. MFT, multifamily therapy. There's so much significant research about actually when we bring families together, including meals, they learn from each other. So one of our basic treatment is we facilitate the treatment. So instead of, obviously we'll make recommendations and we know what we're doing, but it's facilitating the carers, parents or carers, in going back to feeding their children as they always have done. Most of these young people, those parents and carers have always fed them incredibly well until the eating disorder came along. So it's giving back the confidence, giving them the directives, giving them what they need as a resource to go away and refeed their child, rather than reliance on the service and reliance on other people outside of their own network. Guided self-help, that's referring to binge eating disorder specifically. So treatments, so the family therapy, as I said, is our first line of treatment. So I think there's no quick fix. So the actual research at the moment, only 30 to 50% of the young people that we see will that be an effective treatment. So that's part of how chronic an eating disorder can be and how lifelong a journey it can be, dipping in and out of periods of well and ill health. So I just think that's a really important statistic. Only 30 to 50% will actually make a full recovery through this treatment process. Additional treatments, so we have a systemic family therapy clinic, so that's a traditional family therapy if you like. Individual therapy, so we've got a dance and movement psychotherapist, art psychotherapy, we have dietitians, we've parent carers support group, participation group for the young people themselves, body, mind and me group, really just thinking kind of psychodynamically about their relationship to their bodies. Introduction to treatment group is something that we had when we had a waiting list, but thankfully we're not at that point anymore. And the multifamily therapy group, which I've discussed. Okay, what can be done and how? So just a little bit about who we accept. So Anorexia Nervosa, bulimia nervosa, binge eating disorder, EDNOS is no longer a thing, that is now Ofsted, which you might know about, other feeding specified eating disorders. So it's just the kind of so young people presenting with eating disorder but don't fit into the other boxes. So you might have somebody presenting with all the cognitions and all the symptoms of anorexia nervosa, however their weight remains stable. So they would fit into the old EDNOS but now Ofsted category. So ARFID, avoidant restrictive feeding intake disorder, we don't accept ARFID. And the reason for that is they're a very, very unique group of young people and they don't have eating disorder cognitions. So that's your exclusion criteria for our service, is where there's no cognition, so no thinking about body weight, shape, food issues. So to give you an example of young people that would sit in ARFID, that might be young people who have got autistic spectrum or on the autistic spectrum So they may avoid certain foods that is actually having a severe impact on their nutrition and their weight. But we can't treat them with our nice concordant treatment because they're not doing it because they want to lose weight, they're not doing it because they want to look different. They're doing it because they may have sensory issues, or and they might need CBT outside of it. It might be through phobia that they've kind of restricted their intake. And anxiety. We're seeing significantly more and more young people who are presenting with anxiety disorders, and a lot of those will present with feeding issues alongside that. That's not to say that we don't take young people with eating disorders who've got anxiety, because a high proportion, probably almost 70% of our young people have got a diagnosed anxiety disorder alongside their eating disorder. Okay, what do we know about eating disorders and how they come about? So psychodevelopmental factors, so bodily changes, life transitions, sexuality issues. So that's why the onset is most crucial, and we see a big cohort from 17 to 25. So if you think about all those massive transitions people are making in that age range, that's why we get the biggest cohort. We are seeing young people younger. We often get asked, are we seeing people younger? We are. So we've got a couple of 9 and 10-year-olds in the service. Thankfully, that still remains quite rare. And anyone presenting that young, ordinarily the eating issues are around other areas of dysfunction or distress in their lives, but it's not, thankfully, an eating disorder. Socio-cultural factors, so peers, media, lifestyle, family values, different types of abuse that might be present. I'm sure that's impacting on all of your work with everybody media and social media for our young people. It's just creating absolute havoc. Particularly we're seeing body coach, we're seeing all these great diets, and that they're aimed at adults. They're not aimed at children, but children are seeing all these things that are happening to themselves before they've even been developed. Neurochemical genetic factors. So we do know that there's young people who are predisposed due to their DNA to having an eating disorder. One of the most obvious and significant is they're having a parent or family members with an eating disorder. And personality structure. So I'm sure many of you are aware that there is that personality, high perfectionism, that is and that generally still stands as some of the personality structure makeup, particularly for the Anorexia Nervosa diagnosis. Okay, I talked a bit about that. When presenting in the GP surgery, particularly, so just having to think about some things. I don't know who came up with this nips, lips, flips, kiss. I don't know where that's from.
Beat, yeah, beat.
Is it beat? Yeah. Thank you. I was going to say, it's not us. But, there we go, it's got beat on the corner. But it's really, really useful tool, actually. So lips, you will generally see dry lips in anyone dehydrated. You know that just from your generic patients that come to you. Flips is their behaviour changing, I suppose it's it flipping. So parents will often report that they're becoming a little bit more antisocial, spending more time in their bedrooms, be that through exercising or through lots of looking up online. So looking up diets, looking up what other young people are doing, following people on Instagram. There really is some behaviour changes in terms of them becoming quite obsessed with what they're doing. Hips, so that's thinking about how they see their own body. So when body dysmorphia has set in, so they see something quite differently to what you or I might see, they're really, really unwell by that point. Really, really unwell. So we know that their brain matter has decreased significantly and their rational thinking has long gone. So the part of getting better and then being motivated to get better has gone. So they are the most significantly unwell young people when we get to that point. Hips, so just thinking about actually what energy they've got left at the end of the day. So really exhausted. It's a bit of a red herring as well, the hips, because actually what we know is an increase in exercise. So young people will also be excessively skipping, it's got there, so increasing their exercise and trying to do additional pull-ups, sit-ups in their bedrooms. And nips. Do they disappear to the toilet after meals? Okay, I'll briefly go through this. I think you'll probably most of you are pretty much aware of what anorexia might look like, but I don't want to make assumptions. The key thing with anorexia nervosa is the weight has to be less than what's expected. So we have, I said earlier, atypical anorexia nervosa, where the weight can be and remain in a healthy weight range. For us, BMI is totally irrelevant in children. Absolutely beyond irrelevant. Please don't think BMI in children. So we use weight for height. There's an app that you can download so that you can just very quickly work out weight for height yourself. That's your biggest indicator in terms of thinking about referral to us as well. I've got a little slide actually that demonstrates the difference in weight for height and BMI. Fear of weight gain, abnormal, we've talked about abnormal perceptions of their body's weight and shape. Yeah, and how they feel about themselves is directly linked to how they think they should look. So bulimia nervosa. So these can probably, young people, be more tricky when they come into your surgery, when they are presenting with a healthy body weight range within the correct range of their age and height. There is so much shame and guilt attached to bulimia and binge eating disorder, and we've got a very well-versed social construct at the moment of eating disorders of it's your choice, you chose this. And those young people presenting with bulimia very, very much are married to that, and the guilt that they feel means that they often will never disclose for months and months their true binge purge, if that's what they're doing as well, amount. They're thoroughly ashamed by their behaviour. So they will likely be underreporting, and that can be really tricky for primary care because you've got someone underreporting what their behaviours are and they're sitting within a perfectly healthy weight range. So it can be really, really difficult. You'll see more of a fluctuation in weight actually with bulimia nervosa, so you may have someone who's presenting with thoughts around their body and how they feel about their body, and for you tracking weight is probably really useful because the up and down. Thank you. So what you might notice, I'm going to skip that one actually, so the loss of weight, fainting, dizziness, lack of energy, poor sleep, swollen glands under the jaw. Young people report feeling cold, muscle weakness, constipation, feeling quickly, soul bloating. So constipation, I've got 5 minutes left, so I'm going to quickly whiz through and just talk a little bit about that. Family are quite good at noticing what's going on. One of the things that has shifted actually is that wearing baggy clothes isn't such a big thing in eating disorders anymore actually. So you will find young people presenting much more in the usual fashion, and 20 years ago if someone came in wearing lycra, you'd go, they haven't got an eating disorder, they're wearing lycra, they've just fully got their body in shape. That's really, really shifted. So that's not necessarily a kind of a thing anymore about wearing baggy clothes. Warm clothes, yes, because they will be incredibly cold, but not the baggy clothes. Okay, you've got this, and hopefully you'll have a copy of this. So the SCOFF questionnaire is something that you can use yourselves. It's a very quick, easy score. So it's just literally 1 point for each answer. If they score 2 or more, that's just a very quick indicator for you to think, okay, is this something I need to be thinking about? We use eating disorder experience questionnaires within our service. It's much more detailed, and it looks at all of their eating habits in much more detail. This is just so it actually gives you a range, so the dotted line there is what the norm is. So it's really, really helpful to know that young people will have a peak at their shape weight concerns, and that's perfectly normal. So it's not pretending everyone's on this flat, no one's got any concerns. Adolescents are dieting, as are adults. So the physical assessment. So this is what's really useful to us. So pulse, we'll be looking at the differentiation from sitting to standing. So it's really, really important and really useful to have a sitting and standing pulse and blood pressure. So what we will see in pulse is a change, an increase. Anything over a jump in 20 beats per minute, we send straight to A&E, actually. So no young person's heart should be making that significant jump. Obviously, we wouldn't send it just based on pulse. It would be in association with other symptomology. And a postural drop in their blood pressure. Feeling the pulse, so not using blood pressure machines, just see how weak the pulse is. About capillary refill, squat or sit-up tests, signs of dehydration. So the bloods, we're very happy always to send out our bloods. So inorganic phosphate is probably the one that doesn't get done routinely, but it's probably the most important blood result for us. So often young people will come having had their bloods done. We'll go back and say, please, can we have them done again? We've done them. I'm like, yeah, I know, that's amazing, thank you. And you were brilliant in getting them to us, but it's the inorganic phosphate that we need to help us think about refeeding syndrome. Okay, I'm just mindful of the time. Okay, so this is a little bit about weight for height that I was talking about. So this is a young person who BMI, circled the first circle here, 22.49. So not a significantly high BMI really. However, our healthy weight range for children is 95% to 105% generally. We do look at genetic makeup, but 145% would be quite significantly over that healthy weight range. And yet BMI-wise, actually probably not too significant. And again, someone with a BMI of 14, you might think it's quite low, but actually for a child sitting just in the range of healthy weight range. So please disregard BMIs. Not in adults. Okay, so just thinking about how we work together. I think just in the room with a young person, if you do have any concerns, try not to use any language that relates to how they look or how they feel or food, and just, kind of keeping it, I appreciate how you feel, I appreciate what you're talking to me about, that's really useful to hear your thoughts. So comments, such as this is a phase, or even saying to parents, we'll keep an eye on it because we're not sure this is a thing yet, actually will just speed up their drive to become more unwell. Refeeding syndrome. So we will often ask for bloods to be done twice weekly or weekly by my lovely colleagues here today. And the reason for that is refeeding syndrome. So sometimes they will go straight from our assessment into physical health hospital, and they'll be having their bloods done daily to look out for refeeding syndrome. So when they come out of hospital, it's tailoring it off a little bit, so we're down to twice a week and then down to weekly. So we do have reasons for requesting it, and maybe we need to improve our communication and letters as to why we're requesting it and be more explicit, so that you have a good understanding as to why we're asking for it.
What is refeeding syndrome?
Thank you. Let me go there quickly now. So much on here that we haven't. Okay. So it's a potentially fatal shift in the fluids and electrolytes that occur in malnourished patients. There's a whole blurb about what happens to your insulin and why, and this is where our inorganic phosphate tells us. So when it happens, it's when there's been significant restriction, and the significant restriction can be for a really short period of time. So it might have been only for a week, but they've gone down to 100 calories for a week. So it's a really tricky one. So you could have someone who's incredibly overweight but has had rapid weight loss, so still sitting within a healthy weight range. It's the speed of weight loss and how significant the weight loss is. So a young person, we will have young people who sit at 100 calories or 50 to 100 calories before they get to us, and they've been like that for a week. If we increase any food into them at that point in time, their electrolytes are going to go off the wall. And at risk of heart attack, seizure, respiratory failure. So we have had young people who have presented and had seizures in our assessment from refeeding syndrome. It is a thing, it's incredibly dangerous, and that's why generally we will send them straight to hospital for admission, so that their bloods can be done daily, and their food intake is managed really. We work on a 5-day meal plan, so the calories are just gently increased day by day, and the bloods, we wait and see the blood results before we can do a safe increase. So in your clinic rooms, milk is your safest recommendation. So anyone who's presenting incredibly underweight, ill, but you are concerned about risk of refeeding, milk and more milk is always a safe. It's got inorganic phosphates in it, so it's going to be doing a lovely job of keeping the phosphates where we want them. And you almost can't really drink too much milk, that you're going to throw off the electrolytes significantly. So even just asking a young person to increase their milk intake. Right, I've been given enough time. Thank you very much. Does that answer your question on refeeding?
Thank you.
Yeah, sorry. I'm aware that's probably a lot, so over to you for questions, and I'll see if I can.
Same goes for other dairy, like yogurts, cheese.
Yes, dairy is the best friend of anyone with an eating disorder, any dairy. What we know is food is often much harder for them to get into them. So milk feels a little bit safer when it's a fluid. But some young people will happily do yogurts, many won't. So liquids feel far safer. The bit about milks, so as you probably sure guessed it, young people with anorexia particularly will be on all the Alpro, soya milks, dairy-free milks. They'll be doing everything they can to not be getting calories into them. So they would have to have a calcium-fortified milk to ensure that they were getting what they need for the phosphates. So some of them will have additional phosphates in them.
The 5-day refeeding programme. The 5-day refeeding programme, what sort of calorie increase goes on there?
So, off the top of my head, so the 5-day refeeding programme, ironically, can go on for weeks. So it's called 5 days because it's up to day 5 that we increase the calorie intake. However, it can be much slower for the young person to get to that point. So day 3 can take a week. So it depends what their starting point is, and that's why the dietitian does it explicitly to the young person coming in. So someone on 100 calories might start at only 600 calories for the first day, and then you push up, looking to, depending again on the weight for height, you might be at 2,500 calories per day, you might be pushing 3,000 if they're incredibly underweight. So we pick them up long before they're well. So we will take them back in the community before they are refed. So we're very happy to support as soon as they're physically stable back in the community. It's really looking at their physical health. So once their blood pressure and pulse have returned to the norm, then we are very happy to take back and do that pushing forward with calories ourselves.
What was the app you mentioned? You said there was an app.
Yes, there is, Weight for Height. So I haven't got it on this set of slides. I've actually got it on another one. So I can either email it to...
If you email it to me, I'll send it out with the slides.
Perfect.